Sawant, Dr. Abhishek Kothari, Dr. Shalabh Singh. Shweta, you can come up. Not please.
Respected chair and dignitaries. So I thank AIOC for this opportunity and Dr. Abhishek also to include me in this symposium. So we'll be talking on managing a VIP patient with complaints of floaters and flashes. So this is the outline of the presentation. So we'll go in brief about VIP patients, the symptoms of floaters and flashes, and how we will counsel and manage. So we know that this phrase VIP describes the elevated social status of accorded to influential and prestigious members of the society, including politicians, executives of major companies, celebrities, and other prominent individuals. So this is also called VIP syndrome or recommended syndrome. We all encounter patients who are considered VIPs for one reason or another, and proper management of these VIP patients can offer downstream benefits to a practice or academic institution in the form of bolstered reputation, practice growth, and many a times funding. So this was a study. This was in 1964 by Dr. Wintra, the VIP syndrome, a clinical study in hospital psychiatry. So it seemed that shorthand for how the influence of wealth and the allure of fame can cause doctors to veer into risky territory when they cater to stars. They may reject medical advice, can demand ineffective or alternative treatment. Star drug doctors can actually advise unnecessary or inadequate tests, and they may insist to see by the HOD or the chair of the department, though which actually may not be necessary for all cases. So prerequisites: caring about this person's status and whether to simply treat them the same way you would treat any other patient with the same eye problem. So it's okay to roll out the red carpet, but it's better to follow the SOPs of your practice. Waiting period should be less. Offer preferential appointment scheduling to accommodate the VIP schedule. And your delivery of healthcare to the VIP patient is no different from your delivery to healthcare to any other patients. So you're all aware of this, the last days of the king of pop. So avoid the syndrome, because when doctors allow a VIP patient's broader social status to influence the medical decision making, the consequences can be dire. So you cannot be the supplier of milk, as Dr. Conrad Murray did to the pop star. So don't get extracted or diverted by the VIP status. Think clearly, be relaxed, and stay within the standard of care. So if you come to floaters, because all these symptoms, the specks, the lines, the circles, the cobwebs, which appear to float inside the eye, we cast a shadow in the retina, can be annoying, definitely annoying for all of us. So, but usually decreases with few months of vitreous separation, and sometimes, but very rare cases, can be persistent also. But what actually we have to keep in mind that this can actually lead to reading difficulties in 50% of patients, and 30% can have driving difficulty. There are few reports of suicidal attempts because of persistent floaters. Pathogenesis is not needed, but sometimes you may need to be explained about why actually is happening and what actually is happening inside the eye. So flashes, the physical stimulus, the next symptom, where we have a vitreous pooling part of the retina, usually appears and fades quickly, and there is a specific pathogenesis of this, that we see the vitreous cyanosis part because of posterior vitreous detachment. And I usually keep a very simple rule of telling patients that more than 65% patients above the age of 65 years probably will have a physiological symptom of this posterior vitreous detachment. So it can have intermittent blurred vision or glare or haze, but need to be aware of the complications which can actually cause because of AMD, such like you can have a red blood tear or break. So these patients can be triaged depending upon the symptoms. So symptomatic patients to be re-examined, because there is a possibility of having retinal tear in 3.5% of patients. So, and you can see this patient earlier. So be it a VIP patient or a normal patient. So these are the simulating conditions where we can actually have flashes, where migraine, occipital tumors, subspeciality TIAs have shown to have these symptoms. Glares and halos can be after cataract surgery, is also sometimes after refractive surgery. It can be because of vitreous hemorrhage with PVD and retinal tear, vitritis, or retinal detachment. So these symptoms we need to actually see what actually we are seeing. So examination proper is very important. We see vision, we see anterior segment. There is any history of anti-VEGF injections need to be checked. Dilated fundus examination is depression. Ultrasound can be of benefit in some cases, not OCT. And urgent referral if your anterior segment surgeon is better to refer to a retinal specialist explaining the disease to the patient. So treat peripheral retinal degenerations as an preferred practice. And I usually follow there's some guidelines where actually it helps patients to explain, and so you definitely have some dummy eyes or these illustrations I usually give in the OPD, normal retina for a abnormal retina or a detached retina. So this helps a lot to explain the patients. So you is having retinal break in these patients, you have a retinal detachment, a local detachment in this patient, you have a total retinal, quite a significant retinal detachment, and this is the normal macula. So this helps in explaining and probably planning your treatment part. So treatment as well as reassurance. This patient had floaters and flashes and a symptomatic lattice retinal tear. So it was lasered, and you saw the picture to the patient. Once you can take a pulse photograph, patients are reassured. These are other pictures where you see a horseshoe tear was lattice, a horseshoe tear which has been lasered, laser marks are there, no detachment. These few things probably helps. But if you have a persistent symptomatic floaters in patients, because most of the doctors feel that it's a minor ailment, doesn't require any treatment, but yes, there can be 33% patients who have noticeable vision impairment, migraine, 6 points, but patients can have anxiety, and sometimes, as I told them, they've considered suicide also. So intervention worth considering in cases where you have a significant moderate to severe floaters. So these are the few surgical techniques, lasers and surgery things we followed. So I'm not going into the details of this. This is the chart what actually I give to patients. Very important that the line here is very important. When you examine today, there was no sign of any damage. So this is medical legally also important. So reassurance, always reassurance if you don't have a symptom. But if you have a VIP coming with this condition, I wish you all the best. So conclusions, sound understanding of the basic pathophysiology of the disease. Treat VIP patient as any other patient with needed modifications in the approach, not treatment. Floaters and flashes can be annoying, and the key words to handle the symptoms is patience for both the parties. And this is the VIP I follow, bow to value medical skills, intend to command the medical aspects of the situation, and practice medicine the same way. See you in all patients. Thank you so much for the patient care.
Very good point.
Yes. Yes.
Very good. Any other points? Yes.
Dr. Sweet, a very nice talk. What do you have any experience with a laser visualizers? A pilot comes, a young pilot, he has a floater, and he says that I want to get treated. Vitrectomy might not be the immediate option because the formation of the cataract in that patient in future. So some doctors have even tried visualizers, laser visualizers with 2.2 millijoules, and they say that if you are at a higher range, then the heat gets dissipated, so it might not be effective if you're at a lower range. If you're at a higher range, then you have the risk of this. So what's your experience about this?
I don't have any personal experience because I think we don't have a standardized data also to do visualizers. And somehow I have seen patients post visualizers who have complained more floaters.
Yeah, that is
So,
suboptimal
so I'm
laser is used
hesitant
when
about doing
they say
so.
that.
What's your experience, Dr.
No, I don't, that's why I'm asking.
So basically
outset, I'd like to thank the scientific committee, Dr. Partha sir, for inviting me for this talk. I'll be talking about my VIP patient with a retina symptom, sudden dimness of vision. I have no financial disclosures. So sudden loss of vision is a red flag sign. It's very disturbing to the patient, especially if they are VIP patient, and they require urgent attention. So in my practice, we have a separate enclosure where we deal with sudden loss of vision, and we will directly take the patient for examination without any waiting time. That kind of reassures them, and further we follow up with focused history, thorough examination. Now, symptoms such as metamorphopsia or positive phenomena such as flashing light, floaters, shadow in the vision usually indicate a retinal cause, whereas faded colors, washed out colors usually indicate an optic nerve cause. We have to know whether it's painful or painless, because certain conditions tend to be painful, such as optic neuritis or a pituitary apoplexy, whereas others are usually painless, such as any lesion in the optic tract. Now, binocular or monocular differentiation is essential. Monocular mostly have local causes. Binocular are mostly lesions of the chiasma and above. Now, in ocular examination, visual acuity testing is essential, along with confrontation visual field testing and a perimetry. Most important is to look for RAPD, because presence of RAPD usually points towards optic nerve disease, but there are exceptions. Fundus evaluation, IOP measurement is essential. Now, this is how we do a flashlight test, a swinging flashlight test. This is a normal patient. Direct reflex as well as consensual reflex is observed. However, whenever there is a afferent pupillary defect, things change. On direct reflex on the normal eye, there will be a good consensual reflex as well. But in a patient with optic nerve disease, such as this one in the left eye, there is no consensual or direct reflex. Now we'll see a couple of cases and we'll try to determine what is the cause. So this was the first case, 62-year-old male, sudden dimness of vision in the left eye. He also complained of reduced vision in both eyes. There was no RAPD. This was the fundus picture. So it was a diagnosis of PDR with pre-retinal hemorrhage. So sometimes there can be a pre-retinal hemorrhage in both eyes, which can occur simultaneously. So always monocular, binocular differentiation does not work. We have to look at each individual patient. Moving on to case number 2, sudden dimness of vision in the 29-year-old female. Pain on looking up, RAPD was present in the right eye. Fundus was normal. So this was a clear-cut case of right eye optic neuritis. Again, moving on to case number 3, sudden dimness of vision in a female, known diabetic hypertensive. RAPD was there in the left eye. However, this was a case of CRVO. So extensive retinal conditions can also have RAPD present. So this is not exactly very specific for optic nerve disease. Patient number 4, 58-year-old female, known diabetic hypertensive, RAPD in the right eye, no complaint of pain, and we have this typical pallid disc edema in the right eye. Visual field shows altitudinal field defect. So this was a case of non-arthritic AION. So the final case, 65-year-old male, hypertensive, presented with sudden dimness of vision in both the eyes. Visual acuity was 6.6, pupillary reactions was normal, fundus was normal. This was the perimetry picture, and we can see a visual field loss in both the eyes. MRI was advised, and this is what we could see, a lesion right close to the chiasma. So this was pituitary apoplexy. So we have this algorithm where we differentiate whether the patient has RAPD or not, but this is not absolute. We have to look for individual abnormalities. Fundus abnormalities are mostly apparent on examination in most patients, and whenever in doubt, we have to do a perimetry. Only confrontational test will not suffice, and perimetry is must to rule out diseases where the diagnosis is not very clear. Thank you very much.
So as you emphasize, pupil is extremely important. The patient is complaining of conjugation loss. Miss the pupil exam. Do not ask your staff to dilate, because you miss a very important clue. Patient will be valid, but unless we have checked the pupil and we cannot totally blind, but the fundus will be normal, pupils are blessed, that doesn't mean they are bilingual unless and until neuroimaging is done. So pupils can be normal even in patients with optic, even ischemic optic neuropathies, not in optic neuritis usually because that's too severe. So a normal pupil doesn't rule out a problem, but it's extremely important to document the pupil before dilating in a patient with acute vision loss. Any other points from anyone? Anybody in the audience? Dr. Vaibhav Sethi? But we may show some normal. So take the help of neuroimaging before saying it's normal. Sorry, not neuroimaging, electrophysiology. Yes.
Good morning, everybody, and thank you for this lovely opportunity. So I'll be going through some basics and something very important on how to manage blunt trauma. What do I do? So we must understand before we examine a patient what really happens in blunt trauma injury. The most important thing is the eye undergoes some stages in a fraction of a microsecond: compression, decompression, overshoot, and oscillation. The more important, compression and decompression, and that is where the key lies. There is horizontal globe expansion and peripheral volume displacement, and because of this, there is damage to essential and critical areas which are circumferentially present, and damage to areas of least resistance. The 7 rings of tissue affected by blunt trauma from anterior to posterior are the sphincter tear, the iridodylosis, angle recession, cyclodialysis, trabecular mesh tear, lens subluxation because of zonal damage, and retinal dialysis. These we all know. Blunt ocular trauma can be an open globe, which is a globe rupture, and a closed globe, which is a contusion and lamellar laceration. But more importantly, what we need to know is an entity called occult globe rupture, when something does not seem right, and that is where you have to have high suspicion. When you have low intraocular pressure, extensive chemosis, subconjunctival hemorrhage, which the posterior extent is not defined, there is irregular or deep anterior chamber for examination, posteriorly retracted iris tissue, a peak pupil, hyphema, and vitreous hemorrhage, have a very high suspicion that this patient have a occult globe rupture. In such cases, a UV and a V scan will be very important. Managing a globe rupture would involve wound exploration because we have to note the extent of stellar tear to manage the patient. Tagging recti muscles is very essential to examine the posterior aspect, and stellar tear repair. The 3 zones of injury critically would be zone 1, the cornea up to the limbus, zone 2, the anterior 5mm of the sclera, and zone 3. Why have they divided into zone 2 and zone 3 is because beyond 5mm the pars plana ends there, and so beyond that the retina directly gets involved, and that is why the management also changes. So beyond zone 3 injury, the outcomes are poorer and there are higher chances of uveal, vitreous, and retinal incarceration. So an additional encirclage may be necessary in such cases. The technique of stellar repair which was taught to us was the zipper technique. In zipper technique, you use a micro suture, and the way of doing it is you have to come out just before the margin, go back in, and then take a bite again. What this will do is not just oppose the tear, but also the margin will turn slightly inwards so that there is no incarceration of the tissue. Very, very important. If vitreous is there, do a vitrectomy, not just with the banners. If there's uveal prolapse, gently deposit the uveal tissue, avoiding tissue incarceration, and retinal incarceration if it's there, we have to manage with additional encirclage and with vitrectomy. Posterior segment examination. What do I do? Look at the anterior vitreous stays. Don't forget, it's a very, very important thing that you always should look for, because if there are pigments in the anterior vitreous, it could be RPE dispersed, and the reason could be a dialysis or a tear. A beautiful description by Dr. Vinod Kumar and colleagues shows a buckle handle appearance of the vitreous. This is the vitreous, this is not retina. This is vitreous which has been avulsed at the base. And this happens because it is completely detached from the aura and the pars plana area. This just requires close follow-up. A retinal dialysis as shown beautifully by Dr. Rodrigo in this picture, where the retina detaches from its anterior-most attachment at the aura, and there is no anterior retinal tissue, as you can see in the picture. This differentiates from a retinal tear. And the management, if there is a small dialysis with no subretinal fluid or very minimal SRF, a laser around it or a cryo with margin and the posterior aspect is enough. But if there is retinal detachment or a large dialysis like this, it will require a surgery. Depending on the buckle, most likely if you can manage the small dialysis, or in this case a vitrectomy. Commotion retinae is the whitening of the outer retinal tissue. It happens because retina is inelastic, and when the impact happens, because the shock waves, the outer segment, the photoreceptor, the RB, that is where the damage happens. If it involves the macula, there can be transient vision deterioration also. It has a good outcome mostly. Observation is required, and most recover in a few weeks' time. Some may be left with scotomas if involving the macula. So, very important also in such cases, watch out for a traumatic macular hole which can happen delayed. Commotion retinae has different stages which I will not go through depending on the effect. A traumatic macular hole will be a full thickness defect of the macula and incidence is around 9%. It could be immediate on examination with an acute injury, or can happen also delayed. There is retinal stretching, and because of a traumatic PVD, the retina can have a macular hole. Management in a very small micro hole, 100 to 200 microns, with no PVD, a spontaneous closure has been seen up to 40% of patients over 2 months. So sometimes you can closely observe some patients, but if there is a larger hole, there is PVD and associated ERM, a surgery will be required. Finally, coming to choroidal rupture, which is important in acute phase. After a hemorrhage clears, you can see the rupture. Automatic retinal detachment can happen because of the tears. And an entity called chororetinitis flocculoria, when the underneath sclera is seen because of a split and rupture of the retina and choroid because of high velocity impact. An optic nerve head avulsion can also be seen in very, very rare cases. So finally, the important thing is careful examination. Keep an eye on all the danger signs, and indirect ophthalmoscopy with indentation is always a key. Thank you.
Very good. Very good. Did you mention traumatic optic neuropathy, which is very common actually? Did you mention?
I missed out.
Can you talk about it?
Yes. As ma'am already mentioned, that's one thing I missed out. And pupil examinations is very, very important. Color vision, pupil assessment, and when you have in doubt, it's very, very important to do visual field analysis. That's very nice.
Yeah, because the fundus will look problems.
Yes.
So this is one of the again situations in optic vision loss where fundus looks normal unless you have seen the pupil you will miss it. And it's very common even after a relatively minor temp trauma, like falling from a stool in the house. A patient can have significant vision loss from traumatic optic neuropathy, which is quite reversible with intravenous steroids and followed by oral steroids, just like any optic neuritis. Sometimes a patient may say that it is a blood trauma, but actually they may have missed something. So when in doubt, when the history is little bit doubtful, better to do a CT scan orbit because you might even pick up a foreign body. The patient says it's a blood trauma. They may have fallen on a dirty ground and they may think it's blood. And we were talking about vitreoretinal surgery if the injury is beyond 5 mm. So would you advise vitro? But that would not be a
But
blood.
only insert clutch because of the reason that pars plana is not there, so retina gets involved.
Any vitreous surgery even in a perforating injury is not to be done in the immediate settings.
Yes, correct.
Wait for 10 to 15 minutes. Any points?
Documentation and counseling the patient as well as mentioning on paper would be very essential. Such case, anything you will advise now from your point? Yes.
I just need to explain everything more clearly. We have to be careful to mention all the complications that can come down the line because you should not say that you were
another important point just wanted is to also do a serial follow-up of each patient. They can ensure that it will happen later on
Yes.
in between days or a month, and then they will say that you missed the examination. So please call up for serial follow-ups of these patients with blunt trauma, even though the retina was looking normal.
Especially if there is any vitreous hemorrhage, because that will obscure your inferior periphery. So till the hemorrhage is completely absorbed and you've seen the inferior periphery, they have to come back to pick up an inferior dialysis. Okay, so thank you so much, Doctor. We'll move to Dr. Manisha Nada's talk. Morning everyone. And respect to the dais and thanks to Dr. Partha for this wonderful opportunity. I start this topic on subluxated cataract in a VIP patient. As Dr. Chandra said, it's very important. Dr. Malika said that it's important to counsel. It is important to counsel a VIP patient time and again, and also to counsel yourself. Not to be in panic, explain the prognosis, and go ahead. I think the final thing is your expertise would solve the problem. So subluxated cataractus lens, and that too in a VIP patient, can be a nightmare. So a pre-op evaluation aims at looking for zonular integrity, degree of the subluxation, specific etiology, and any complication in addition to the routine investigations. So indications for this urgent intervention requires to know whether there is a pupillary block glaucoma, intractable uveitis, lens corneal touch leading to corneal decompensation. In children, there is always the possibility of amblyopia. So how to go about the pre-op evaluation in any case of subluxated cataract is we should know what is the lens subluxation, whether it is minimal to mild, when the lens edge uncovers 0 to 25% of the dilated pupil. Moderate, the lens edge uncovers 25 to 50% of the dilated pupil, and whether it's a severe kind of subluxation, and that is up to or greater than 50% of the pupil. We need to know whether there is a phacodonosus as cataract, whether we can see the subluxated lens edge, whether it's a flat lens edge, when the remaining zonular fibers, they are fairly healthy and strong, and round edge of the lens, whether it's visible or not. Pre-op evaluation also includes the change in the position of the lens with posture. If it is there, we have to be careful. UBM is valuable to know the zonular compromise. Lens capsule damaged or it's punctured, intraocular pressure needs to be monitored, and vitreous status has to be seen. So surgical approach is there when we, if it is a traumatic subluxation less than 3 clock hours, attentive surgery is required. There is no need for any capsular support. If there is a mild zonular laxity with progressive pathological state, sometimes there is uveitis going on, use a CTR. And if it's a young patient with progressive diseases, sutured a CTR with scleral fixation, even if the lens is not displaced. So capsulorhexis, how do we go about it? It's always there's a difficulty in puncturing the anterior capsule. We need to use trypan glue dye. The elasticity of the capsule is reduced. Penetration of the bag and propagation of the capsulorhexis is easier if we use some device like hooks and all, and it aids in visualization of the avoiding unintended capsulorhexis. So crossroads capsule pinch approach, you can use that. Microforceps are required or hooks may be needed to steady the lens during the continuous tear. Capsulorhexis is centered on the crystalline lens, that's very important. It's not on the pupil, has to be on the lens. Or the corneal apex, that should not be taken into care. It is the lens which has to be taken care of. The center of the rhexis starts in the lens. Minimum 2 mm margin should be there between the capsulorhexis edge and the equator. We need to stabilize the capsular bag. Flexible iris retractors, they are placed through limbal stab incisions, and there is less than 3 clock hours of zonular deficiency. Stabilization of the capsular bag, if it is more than 6 clock hours, use CTR rings. CTR selection is also based on this. If there is more than 4 clock hours or moderately to severe displaced lenses, we can use a fixation device like standard CTR and a ring segmentation in combination. Need to suture sometimes. So long-term stability can be achieved using a Sioni style CTR or Ahmed type. In cases of severe weakness or progressive disease in younger patients, any combination of these devices could be used.
Phacoemulsification should be done. Hydrodissection and viscodissection, they are critical tools in managing these subluxated lenses. The youngest lenses can be aspirated with irrigation aspiration handpieces, and abundant use of viscoelastics is must. Cortical aspiration has to be taken, a good care has to be taken. The aspiration should be from the anterior capsular rim edge towards the equator and should not be directly sucked from the equator directly. Centripetally it should not be done. That might increase the zonular dialysis. Intraocular lens selection is important. We should avoid accommodating IOLs. One piece or three piece IOLs should be the appropriate IOL for insertion. Toric IOLs in subluxated lenses, they should be avoided because there is a risk of decentration and improper alignment. Possibility of late suture breakage is there. Progressive zonular degradation requiring late lens in the bag fixation with possible IOL rotation is there. So a better alternative is limbal relaxing incisions are given in cases of any astigmatism rather than going for a toric IOLs. Multifocal IOLs, they are beneficial in young children because in atropia lenses, as you see, that there is loss of phakic accommodation. So then multifocal IOL is the better choice. We can use PTFE instead of ninoproline when we use multifocal IOLs. Vitreous prolapse has to be taken care of. That has to be done very calmly and nicely. We should use a pass pen approach, that is better. Once the prolapse vitreous has been removed, place a dispersive viscoelastic over the exposed region. This limits the additional prolapse during any subluxation of the lens. So this is a case which I recently did on a patient, a VIP patient. It did not alter my surgery. So you can see that CTR is placed. This is moderate kind of dialysis. CTR is placed before I took out the soft cortical matter. It was not all that hard. You can chop and aspirate without causing any zonular increase in the dialysis of the zonules. All the procedures are done with care. IOL implantation is planned. You can see it's being placed in the bag and secured properly. The center is nudged. This is how a subluxated lens is tackled with. Different cases need different maneuvers. You should be expert and beginners should take more care. With passage of time we get to learn. Every case can be done with a lot of ease. So thank you very much, Dr. Joshi.
Thank you, madam. So in case of subluxated lens you have, comes with the trauma, the least traumatic approach, what would be your least traumatic approach in those kind of cases? What kind of, whether would you like to try the same lens and do multiple procedures which have been described, or would you like to explant and come back with a new lens in those cases? And if yes, what would be your choice of still fixated IOL?
For me, I think I can manage the subluxated lenses this approach which I showed you. In a similar manner, I do in any VIP case also. And regarding scleral fixated lenses, I use sutures. I use duoproline and fixate the IOL on the standard previous style kind of situation, not the new glues I don't use, and CTR can be used as if required. nothing more than that. If CTR is required, I do, otherwise.
So there are various still fixated IOS techniques. Dr. Abdul Mustaki has Dr. Mike was a beautiful video about how the both RD as well as the SFIOS, choice of the SFIOS. Any comments from the chairperson? The choice of the SFIOS, the sutured versus sutureless. In sutureless, you have so many varieties now. Sergio Canabrava technique with 5-6-proline is also being used. The dumbbell shaped technique. Or the Yamane, of course, the modified Yamane, the Indian Jugards have started happening now. Various people starting their own technique and calling it as a modified Yamane technique. So, any comments from this side? Sir, what's up?
But I use only tenoproline for this suturing. Never depend on
the only disadvantage with these tenoproline is now we are seeing the degradation which was done 15 years back.
That is true.
And I have shown a series of cases where we do the dangling SFIOS where we try to just hook up the thread in the vitreous cavity and bring it back. Either you can use a tenoproline or you can use 6-proline inside the vitreous cavity to thread it in the eyelet of that SFIOL and then bring it back and then you can flange it. So there are various multiple procedures also being discussed in the dangling. So I think any experience about anybody in the audience regarding the Gore-Tex SFIOS, and they are said to be the best. So if we are thinking that there is any VR intervention going to happen in future, then I think the stability of these SFIOLs is very, very important because the 2-point sutured SFIOLs will not give that kind of stability as with the 4-point fixation. Or with the kind of Gore-Tex securing the 4 places, the suture knots, I think that's going to be more stable. The only thing we worry is the oil or the gas coming into the anterior segment. And we all know that if gas comes into the anterior segment, especially the CTFA, it's definitely going to cause more damage to the cornea and the increased glaucoma as well. So any thing, yes sir, about the goal. Come on sir. Gore-Tex, sir. Very interesting. I think you should publish it, sir, so that yeah, because many of us would like to know. Because as we all know, from the outer side is it's a very safe this thing, but definitely these kind of reports will definitely help us. Well, what might be the reason for the for this increase? Because this buckle also be used.
close the session now. It's time up. Next session of the year also. Thank you very much.